My name is Andrew Wahl. I am an associate professor in the Department of Radiation Oncology, and my talk today is on the management of the axilla following neoadjuvant chemotherapy for breast cancer. We will today go over the historical and modern perspective of breast, chest wall, and regional nodal radiotherapy. And we'll talk about neoadjuvant chemotherapy and local regional recurrence. The focus will be on the regional lymphatics. However, it is often difficult to disentangle treatment of the breast or chest wall from treatment of the lymph nodes. Following that discussion, we'll talk about radiotherapy field design and then discuss future directions in clinical trials. So a talk about breast cancer would not be complete without mentioning the improvements in survival seen in patients who undergo adjuvant radiation therapy following mastectomy. 3 trials published in the late 90s and early 2000s showed an improvement in survival of about 10% in patients who received post-mastectomy radiation therapy and who had advanced breast cancer. In patients who undergo breast conservation followed by radiation therapy, we see significant improvements in local control, seen here on the graph on the left, and that translates into improvements in breast cancer mortality at 15 years, seen here on the right. In patients who have lymph node positive disease and undergo breast conservation surgery, we see a greater improvement in local control and correspondingly a greater improvement in 15-year breast cancer mortality. So in patients who have higher risks of local regional control, in excess of 20%, you could see improvements in breast cancer deaths at 15 years of about 6%. In patients who have reductions in 5-year local control from radiation therapy of 10 to 20%, we see improvements in survival, breast cancer survival about 5%. And when patients' risks of a local regional recurrence are low, radiation has minimal impact on breast cancer survival. The same group also did a meta-analysis of patients who received nodal radiotherapy. They looked at roughly 13,000 patients, 14 trials of patients who received nodal radiation therapy versus none. If you looked at the patients who were enrolled in trials dated from the 1960s and 1970s, the authors found that the estimated mean heart dose was over 8 Gray, which would be exceedingly high by modern standards, and they showed that there was no benefits for regional nodal radiotherapy. There was actually a decreased 20-year overall survival of about 2.8%, which seemed to correspond to an increase in non-breast cancer mortality. When they looked at modern trials from 1989 to 2003, this group found that the estimated mean heart dose was much lower, of less than 8 Gray, and regional nodal radiation therapy reduced the 10-year risk of any recurrence by 3.2%, breast cancer mortality of 2.8%, and overall survival by 2.9%. So these numbers were significant, and especially relative to randomized trials that we have recently been published. So while those patients were treated with adjuvant chemotherapy, if it was indicated, neoadjuvant chemotherapy has become more commonly used. It's often used for locally advanced, both resectable and unresectable locally advanced breast cancer. It's used for inflammatory breast cancer. It's used in patients who desire breast conservation and who would like to be converted from a mastectomy candidate to a breast conservation candidate. Also, early stage breast cancer patients. This is slightly more controversial. It's certainly physician or institutional preference guided. It may select the appropriate patients for further adjuvant treatment following surgery and radiation therapy, and it's ripe for clinical trial enrollment. So to review a couple of older NSABP trials, both B18 and B27, these patients in B18 were randomly assigned to upfront surgery followed by 4 cycles of AC versus the same chemotherapy followed by surgery. In patients who were enrolled on NSABP B27, they had operable breast cancer. They were randomized to AC times 4 followed by surgery, which was essentially the B18 arm, versus AC followed by docetaxel for 4 cycles followed by surgery, or AC times 4 cycles followed by surgery followed by docetaxel for 4 cycles. In these protocols, the radiation was standardized. After breast conserving surgery, whole breast radiation was given without regional nodal radiation therapy, and after mastectomy, no post-mastectomy radiation therapy was permitted. T4 and N2 patients were not included. Most of these patients, 70 to 85%, were T1, T2 clinically, and clinically node negative to clinically N1. This standard radiation therapy allowed authors to go back and retrospectively look at this data that was collected prospectively and evaluate local regional recurrences. And in patients who underwent mastectomy, I will show you to the green arrows where these patients had small tumors at diagnosis, less than 5 centimeters. If they were node negative, their risk of a local regional recurrence was 2.2% in the chest wall and 4.3% in the lymph nodes, and 0 patients recurred in patients who were clinically node positive. I'll also direct you to the red arrows. These patients had residual nodal disease following surgery, and they had higher rates of local regional recurrence, 7.8% in the chest wall and 3.4% in the nodes, or 10.8% in the chest wall versus 6.4% in patients who were clinically node positive and then had residual disease following neoadjuvant chemotherapy. The bottom slide shows patients who had tumors that were larger, over 5 centimeters, and if they had a pathologic complete response in the breast and lymph nodes, they had about a 5% risk of a local regional recurrence, and if they were node positive, there were no local regional recurrences. And then if you look at the red arrows, 12.3% risk of a local regional recurrence to the chest wall, 2.3% in the lymph nodes. And in patients who were node positive and had larger tumors, the risk was 17.6% in the chest wall area and 4.8% in the lymph nodes. The graph on the right shows that you could predict the risk of a 10-year local regional control by tumor size, and then response to chemotherapy based on nodal status at diagnosis and the response to chemotherapy. Of course, it should be pointed out the numbers in the pathologic complete response groups were quite low. For example, in this subset, it was 21 patients, in this subset, 11. So this was certainly thought-provoking. They also looked at lumpectomy patients, and I will show you the same thing and direct your eyes to patients who were clinically node positive, had lumpectomy and breast radiation, and these all had breast radiation. They were over the age of 50. The risk of a breast recurrence at 10 years was 7%, but a failure in the lymph nodes was 7.5%. In patients who received the same treatment and were under 50, they were clinically node positive and had residual disease in the nodes, the risk of a breast recurrence was 14%, and risk of a nodal recurrence was 8.7%. The CT NEO-BC pooled analysis was a meta-analysis of neoadjuvant chemotherapy trials, and they went back and retrospectively looked at local regional recurrences based on tumor subtype. And these were the 5-year rates of local regional control based on response, pathologic complete response here, residual disease in the breast here, but pathologic complete response in the nodes, or patients who had residual disease in the nodes following neoadjuvant chemotherapy. And you can see patients who had high-grade disease or HER2 positive disease or triple negative disease, they had high rates of local regional recurrence. And if you had residual disease in the breast but were node negative, you saw slightly lower risk of local regional recurrence, but still certainly concerning. And as opposed to the NSABP patients who did not have any post-mastectomy radiation therapy, it was estimated that across these protocols, that made up this meta-analysis, about a third received radiation therapy. What about the 5-year rate of local recurrence following lumpectomy? Same breakdown. They included age breakdowns, and this becomes quite a busy table. So I'll just direct you, of course, to the fact that patients with high-grade disease or had aggressive HER2 tumors or triple-negative tumors, if they had residual disease and lymph nodes following chemotherapy, they had unacceptable rates of local regional recurrence at 5 years. Also, if they had residual disease in the breast, they also had slightly higher risks of local regional recurrence. So general principles of radiation therapy following neoadjuvant chemotherapy. Well, today, following breast conservation, whole breast radiation therapy with or without regional nodal radiation therapy is recommended after mastectomy. Due to patient selection of those who typically receive neoadjuvant chemotherapy, most patients do receive post-mastectomy radiation therapy. Of course, the exception are the early stage patients that I mentioned earlier. However, regional nodal fields, radiation fields that is, often vary. They may include the internal mammary lymph nodes, or they may not. What happens in patients who have sentinel lymph node or targeted dissections who have a clinically positive node? What about patients who have a pathologic complete response? What about patients who have axillary dissection? What is the extent of axillary radiation therapy coverage? So several studies have helped guide us, and this is kind of where it becomes difficult to disentangle regional nodal radiation therapy completely away from treatment of the chest wall or breast. This is 4 separate retrospective reviews of data from MD Anderson, comparing patients who have post-mastectomy radiation therapy versus not, of which regional nodal radiation therapy would have been a component. And these patients were studied in several settings. So in patients who had clinically N2 or clinically N3 breast cancers when with neoadjuvant chemotherapy, those who did not have post-mastectomy radiation therapy had a 40% risk of a local regional recurrence, which was quite high. In patients who had a pathologic complete response and stage 3 tumors, their risk of local recurrence without radiation was 33%, and that went down to 7.3%. If you look at 5-year local recurrence for young patients with stage 2 or 3 tumors, the risk of local regional recurrence was 37%, with radiation was 12%. And in patients who have clinically CT3 tumors, but node negative, their risk of radiation without post-mastectomy radiation therapy was 24%. It went down to 4%. Again, these were retrospective studies. Some of these cohorts were quite small, but this was some of the early data on local regional recurrences following the adjuvant chemotherapy. And again, I'll point you to the NSABP trial that we mentioned earlier, the B18 and B27, looking at response rates being a very strong predictor for local regional recurrences. The patients, so what do you take home from these studies? Well, no post-mastectomy radiation therapy was allowed in the NSABP studies. The MD Anderson studies had subgroups that did not get radiation. But a couple of conclusions: in patients who have a pathologic complete response in the nodes, the risk of local regional recurrence is low. And that begs the question, can we avoid radiation therapy? In patients with residual disease in the lymph nodes, the risk of local regional recurrence can be 15%, and in some cases, over 20 or 25%. In these cases, radiation would be expected to offer a more substantial benefit, and potentially these patients would be at higher risk even with post-mastectomy radiation therapy. So some general principles of radiation therapy following neoadjuvant chemotherapy. 1, after breast conserving surgery, again, whole breast with or without regional nodal radiation. Again, mastectomy patients, most patients should receive post-mastectomy radiation therapy with regional nodal radiation therapy. Absolute indications would be patients with inflammatory breast cancer or who have locally advanced disease defined as T3 or likely T4 and N2 or N3 disease. These patients have high risks of local recurrence without radiation, regardless of their response. What about residual nodal disease following neoadjuvant chemotherapy? Those patients should probably receive radiation therapy to the breast and chest wall with regional nodal radiation therapy. But a question that's up for study is patients who are clinically node positive and have a pathologic complete response. What should we do with them? And then again, maybe no post-mastectomy radiation therapy for those patients who have early stage T1 or T2 breast cancers that are clinically node negative. There may be some exceptions when patients who are very young, who have lymphovascular space invasion, ER negative disease, and tumors that clinically are closer to 5 centimeters than they are 2 centimeters. We may consider radiation therapy in some of these patients, but that would be an uncommon situation. So what are the appropriate treatment fields? Because there are many different situations that a radiation oncologist will find themselves in this setting. What about patients who convert from a CN1 to a pathologic complete response? Some of these patients may have had an axillary lymph node dissection. Some of these patients had a sentinel lymph node biopsy and a targeted dissection. What about patients who are clinically node positive and then have residual disease? Again, same situation. They may undergo one or the other surgeries, either full dissection or sentinel node with a targeted axillary dissection. And then they may end up declining a dissection following a small amount of cancer in a sentinel lymph node. And then the question is does radiation therapy to the complete axilla have a role? So this is complete axillary and supraclavicular radiation therapy. We often use obliques, and that allows us to cover the deep lymph nodes that sit in the central portion of the axilla. So up on the top slide here, we have kind of an oblique from the anterior position. This is a posterior oblique. And we have here inclusion of level 2, level 3, supraclav. And then I'll also point you to level 1, which allows, and you'll see this lateral jaw pulled wide open to cover the lateral aspect of level 1 as it comes up just above the match line there. And potential indications for this treatment would include patients who have a sentinel lymph node biopsy only, or who have no axillary dissection or inadequate dissection, or patients with a heavy nodal burden. In patients who were enrolled on the Canadian MA20 trial, 10 lymph nodes was used as a cutoff for nodal radiation, as defined as whether it would be inadequate or an adequate dissection. Although those numbers can vary, that was at least one protocol's definition. There are some centers that treat full nodal disease in most, if not all, circumstances. And of course, this would lead to higher rates of lymphedema or shoulder stiffness or shoulder stiffness. Not at our institution, it's not what we commonly do if they've already had an axillary dissection with very limited disease. But one thing that one has to note is that level 1 and portions of level 2 are often included in the chest wall or in the breast tangential fields. So what I'm pointing out in this slide here in light blue is the PTV. The green background is level 1 and level 2 as it extends into the lower and inferior axilla. And in pink here is the internal mammaries. And we often have to pull the block and pull our jaw posterior to cover the axillary disease in green. In this case, the internal mammary nodal coverage helped with pulling that block back and allowed for some adequate coverage. But if you're not careful, it's very easy to put a block right along the posterior aspect of the chest wall, or in other cases, the breast field, which might even come further anterior. And thus you would have a cold area of level 1 or portions of the inferior level 2. What about more limited axillary lymph node and supraclavicular radiation therapy? Often at Nebraska Medicine, our surgeons leave a clip or two at the most superior or superior medial aspect of their dissection. And that allows us to identify where they stopped their surgery, and we're able to move our blocks appropriately. In this case, we were able to move the block to the midhumeral head. She happened to have some level 1 disease that went more lateral, but there are certainly cases where the field border can stop at the coracoid or at the most medial aspect of the femoral head, just treating levels 2, 3, and the superclav. So conclusions: neoadjuvant chemotherapy can result in high response rates and can increase breast conservation rates. Patients with complete response may benefit from decreased local failure in the future, or they may benefit from decreased local therapy in the future. On the other hand, neoadjuvant chemotherapy may select for patients with high rates of local regional relapse who deserve more aggressive radiation therapy, with systemic therapy either given concurrently or adjuvantly. And then radiation therapy fields vary in clinical practice. This has been seen in review of fields from the Alliance protocol, and I believe some of the future trials will help answer some of these questions. So ongoing clinical trials in these situations: the RAD-COMP trial is a proton versus photon radiotherapy trial. It does really improve dosimetric plans, improve clinical outcomes in breast cancer patients. RT-CHARM is patients who undergo mastectomy with nodal evaluation, and they undergo conventional radiation therapy at 50 Gray and 25 fractions to the chest wall and nodes versus a hypofractionated approach to the chest wall and nodes using the Canadian fractionation of 4256 and 16. In this protocol, regional nodes levels 1, 2, 3, superclav, and intramammary were included. If an axial lymph node dissection was performed, radiation was not directed to the dissection area. It was only to the undissected axilla. The NSABP B51 NRG 1304 trial, RTOG 1304 trial, excuse me, was a protocol that was opened here. It was T1 through 3, N1 patients. They were core or fine needle aspiration, so biopsy proven with a clip placed on the node. They underwent neoadjuvant chemotherapy, and they had mastectomy or breast conserving surgery. And if they had a pathologic complete response, they were randomized. And if they had mastectomy, they did not receive post-mastectomy radiation therapy. If they had a breast conserving surgery, they received whole breast radiation therapy without nodal radiation therapy, or they were randomized to regional nodal radiation, so that would be whole breast with regional nodes, or if they had mastectomy, they did receive post-mastectomy radiation therapy to the chest wall and regional nodes. The Alliance trial, same patient group, they underwent neoadjuvant chemotherapy. This was a sister trial to the NRG trial. And in these cases, they had residual nodal disease on dissection or sentinel node biopsy, or at least on sentinel node biopsy, I should say. And they were randomized to dissection without radiation to the dissected axilla, but they did get radiation to the undissected axilla, or no axillary dissection with radiation to the axilla and the regional lymph nodes. The last trial that I will mention that completed accrual several years ago was basically an observational, prospective study, observational only. This is from the Netherlands, where they took N1 patients, they gave them neoadjuvant chemotherapy. If they had a path CR, they had a whole breast radiation therapy following lumpectomy with or without a boost. If they had a mastectomy, they did not receive post-mastectomy radiation therapy. So future directions: can each one of these protocols identifies outstanding issues? Can complete axillary nodal radiation replace dissection in patients with residual nodal disease following a sentinel node biopsy? That would be addressed by the Alliance trial. If patients have clinically node positive disease and then a pathologic complete response, can we reduce the treatment fields following a lumpectomy, just treating breast only? And can we omit post-mastectomy radiation therapy? That would be addressed in B51. And then the role of hypofractionation by RT-CHARM and protons by RAD-COMP. So we need to identify groups of patients who are at high risk of local regional recurrence after our best systemic therapy, surgery, and radiation. We can do that by looking at response to neoadjuvant chemotherapy. We can look at tumor biology, likely the triple negative or inflammatory patients. and identify novel biomarkers. And these situations potentially incorporate radiosensitizing agents or alter our dose fractionation regimen. Our triple negative patients are the most complicated. Local regional recurrences can be 20 to 25% after lumpectomy and 22% after mastectomy. And there's many different subtypes of triple negative breast cancers, all that potentially have targets that we could look at in terms of improving our local regional control rates in these patients. So I thank you for your time and appreciate the invitation to speak today.